everyone. Thank you for being here today. You are at the webinar presentation of Rick Haverkate with IHS. This is part of the AIHEC Health webinar series, and my name is Maggie, and I work on the Health Initiatives team at AIHEC. We are grateful for you joining us today. For those who are brand new, welcome. We do host regular webinars. We do have just one more December 5th in this year, but then we're going to get right back into it in the new year. So continue to look for that to come your way. So Rick Haverkate is an enrolled member of the Sault Ste. Marie Tribe of Chippewa Indians in Michigan and grew up in the land of his ancestors along Lake Superior shores. In 1993, he earned a Master of Public Health degree from the University of Hawai'i. His public health work has focused almost entirely on American Indian, Alaska Native, Native Hawaiian, and Pacific Islander populations. Rick has assumed various roles, including Community Health Educator, Public Information Officer, Public Health Advisor, Principal Investigator, Project Officer, Director of Public Health, Senior Program Analyst, and Deputy Director at the local, state, tribal, and national levels. He has specialized in operational management in the fields of HIV/AIDS, maternal and child health, commercial tobacco use prevention, health promotion, disease prevention, and community capacity building. Rick currently works for the Indian Health Service as the branch chief of their national HIV/AIDS branch. So again, a huge welcome and thank you to Rick Haverkate.
Well, thank you very much. It's so nice to be here. I appreciate Eric and Maggie reaching out, inviting me. So I want to talk a little bit today about some work that we're doing in the field of HIV and the syndemic approach that we're taking to HIV. So I'm just pulling up my PowerPoint here. Hopefully that'll work. Everybody can see that. But I really appreciate the attention that people are giving to HIV. This is a group that we've been we've had at the top of our list for a long, long time. So this is really a great answer to some of the hopes and dreams that we've had, is really get our message out to the tribal colleges and universities. I think sometimes people think that, oh, that's the old message of HIV, and aren't we past that yet? And isn't there a cure for that? And we never hear about it in the news anymore. But no, it hasn't gone away. And what's happened actually is there's a whole syndemic now. So syphilis, if you haven't heard yet, is making a huge impact in Indian country these days. I mean, some of our states in the upper plains have seen like a 900% increase in new cases of syphilis diagnosis. We've seen a dramatic increase in fetal deaths related to congenital syphilis. We have huge numbers of hepatitis C, especially in the upper Great Lakes and the upper Plains states. American Indian, Alaska Native people have rates of hepatitis C that are way, way, way above what's going on in the general population of the U.S. We have the highest rates of things like hepatic cancer, which is liver cancer, and the main cause of that in American Indian, Alaska Native people is hepatitis C. So we can't just look at one thing anymore. Even though I'm going to talk a bit about HIV today, I really want to bring home the message that it's so many things are related. And then there's the idea of things like housing, homelessness, education, employment, stigma, all those things that relate into the biomedical things that we call HIV and hepatitis C and syphilis. So nothing ever stands alone, right? And we have to always remember this holistic approach to healthcare when we talk about prevention and response and treatment of people living with things like HIV. But we can't leave out people getting to behavioral health, looking at mental health status, talking about substance use disorders, bringing this into creative places like into the dental operatory, talking about it at every visit, maternal child health visit, doing education with our providers around taking a sexual health inventory, making sure that we are making our tribal, urban, and IHS facilities more welcoming to everybody, and specifically people who identify as Two-Spirit or LGBTQ. So lots and lots of very interesting topics. I hope to touch on a little bit of them today, tell you a little bit of what's going on nationally with statistics, as well as some of the programming that we're doing. But let me start off with a couple little commercial breaks here in between, so you don't get too bored of just listening to me. But we're working really hard with some really incredible PR folks to talk about how we bring the message into places like our waiting room. So there's a really cool thing called Good Health TV, and I don't know if you ever been to a tribal or IHS or urban clinic where they have a TV screen playing up on the wall and really good, innovative information for the gamut of good health for American Indian, Alaska Native. But let me play you one of the commercials that we've worked on.
Let's talk about HIV. It's a virus that attacks the immune system and is spread from one person to another through blood, semen, vaginal secretions, and breast milk. Anyone can get HIV, but some people are more at risk than others due to many factors, including the status of their sex partner, their behaviors, and prevalence in their communities. PrEP is a safe and highly effective medication that can reduce your risk of HIV. If you're at risk for HIV, it's time to make prevention a priority. Talk to your healthcare provider to find out if PrEP is right for you.
Yeah, we'll see if I can go back to my presentation. So how many people have heard about PrEP? I can't see all your hands, but anyone know what pre-exposure prophylaxis is? Do you know there's biomedical interventions that virtually make it impossible to acquire HIV? It's one of these things that we thought about 40 years ago when we first started hearing about this weird new disease, HIV, which was leading people to die from AIDS within 2 years of their diagnoses. But we never even dreamt this was possible. Back in about 2012, the FDA approved a drug called pre-exposure prophylaxis. And a person who is HIV negative can take this one pill once a day, and it prevents about 99.9% of transmission of HIV through sex. It's pretty good about preventing it through injection drug use as well. But studies around the world, Africa, the US, Asia, sub-Asian continent, have shown the benefits of taking PrEP. Now there's an injectable form that you can take once every 2 months. There's a little bit of interaction with your pharmacist and your doctor and your care team. You have to come in every 3 months for blood draws to make sure that it's not affecting your kidneys or not affecting your bone density, see what your side effects are, but the side effects are pretty darn low. But when you think about this biomedical intervention of a pill that literally prevents someone acquiring HIV. Another thing that we really want to talk about, some miracles of modern science in the biomedical intervention, is for people who are living with HIV. So if you're a person who has a diagnosis of HIV, you can get on these antiretroviral therapies within maybe 12 weeks, a couple of months. Your viral load will basically vanish. You'll have like an undetectable viral load. Once you get to that state, you're virtually incapable of then passing that virus on to someone else. So we've got two incredible new tools in our toolkit. Getting people who are living with HIV into care, keeping them there, getting them to an undetectable viral load. They are not capable of passing the virus along. And people who are negative, but doing behaviors that are human in nature, like having sex, you're virtually incapable of acquiring HIV. So we want to keep driving home the message about condoms, but these two biomedical interventions, I think, are exciting news, and I think a lot of people don't know about them yet. So I wanted to make sure I got that out there front and center. But we're trying to really promote the idea of getting people to talk to the providers about PrEP and your student health centers, getting people in the community to talk about PrEP, really getting the message out there and destigmatizing the idea of just talking about, hey, I'm a human being and I have sex and I'm worried about HIV for one thing, but how do I prevent it? So let's make sure that we get this messaging out to our clinicians, our providers, students, anybody who thinks about preventing HIV. So I think it's just such really good news. For a long time, we were just scared to death if anyone even talked about HIV. Now, I did want to go through some of the statistics of HIV. And these are a little bit old. We're compiling our new data. You probably are not going to be surprised at the fact that getting data for American Indian and Alaska Native people is pretty difficult. The majority of people who qualify for IHS don't go to an IHS federally run facility. They're going to tribal healthcare, urban Indian organizations for their healthcare, going to non-native providers. Their favorite provider might not be part of an Indian healthcare system. So getting all that data compiled is really difficult. The one thing we can rely on is reportable diseases like HIV or hepatitis C or syphilis. No matter where you test positive, that entity almost always is required to report that up through their county health department, their state health department, and eventually on to the Centers for Disease Control. So the data you're going to see here today looks a little bit old. We do have the newest data up through 2021. Right, it's in the final stages of clearance, and I'll be able to report that by probably the end of this month. But for this presentation, this is the publicly available information I have.
Hello, this is Rick Haverkate. I'm the National HIV and Hepatitis C Program Coordinator for the Indian Health Service. This short presentation will provide you an update on HIV for American Indians and Alaska Natives in the U.S. I based this brief update on the latest available HIV statistics for American Indians and Alaska Natives. I'm using data from the Centers for Disease Control and Prevention reported through December 2019, which includes but is not limited to data from the Indian Health Service. A word of caution as I begin. As shown in multiple studies, and due to missing or misclassified racial data on various health conditions, national disease surveillance data may undercount American Indian and Alaska Native people. The IHS Division of Epidemiology and the CDC are updating HIV data using more recent internal IHS data. HIV is a reportable disease as part of the CDC's National Notifiable Disease Surveillance System. Like all health system providers, the IHS facilities report notifiable diseases to the respective state health authorities, which transmit the data to CDC. The CDC publishes their HIV surveillance report annually. So, let's look at the most recently available American Indian and Alaska Native HIV data. The data comes from the individual states, which report their diagnoses of HIV to the CDC through December 2019. Once the states transmit their HIV data, the CDC's National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention collects and analyzes the data and makes it available to the general public. The figure on the screen is taken directly from the National CDC report, and it shows trends of new HIV diagnoses by race and ethnicity. This graph you see is not fully inclusive of all races in the U.S. For this slide, I've zoomed into a smaller chart of racial groups with lower rates of new diagnoses, and that explains why it does not include all racial and ethnic groups in the U.S. To access the full report, you can scan the QR code on the screen using your smartphone. Although we see some slight variations from year to year, we consider the new HIV diagnoses trend from 2014 to 2018 as stable. The HIV diagnosis rate is approximately 8 per 100,000 for American Indians, Alaska Natives, compared to 5 per 100,000 for whites. Remarkably, in this report, we see that the death rate among American Indian and Alaska Native people living with HIV in 2018 is 30% lower than it was in 2014. The American Indian and Alaska Native death rate has been lower than the white rate for the past 2 reporting years. We cannot infer any causation on a national scale. Still, we do know that our larger IHS-operated HIV treatment programs like the Phoenix and Gallup Indian Medical Centers show outstanding HIV testing, linkage to care, and viral suppression outcomes among their HIV patients. Because our smaller IHS, tribal, and urban Indian health clinics often refer their HIV patients to specialty clinics outside the Indian health system for treatment, it's challenging for our systems to keep track of their individual cascade of care. Next, let's look at the HIV transmission mechanism among American Indian and Alaska Native people in 2018. The CDC data shows that the majority, or 84%, of the reported HIV diagnoses in American Indian and Alaska Native people were among men. Most of the documented HIV transmission among these men was male-to-male sexual contact, accounting for 75% of new diagnoses. The second most common transmission route is injection drugs combined with male-to-male sexual contact, accounting for 15% of new diagnoses. Among American Indian and Alaska Native women, heterosexual contact at 57% was the main transmission route, followed by injection drug use at 43%. Other statistics include a recently published CDC report on American Indian and Alaska Native adults in HIV care. This national monitoring project uses in-person and phone interviews that CDC conducts with persons in HIV care. The project seeks to understand better and document the experiences and needs of persons in HIV care. The analysis concentrated on patients who self-reported as American Indian or Alaska Native. These data showed robust patient adherence levels and some room for improvement on viral suppression, which is a crucial indicator for both patient health and preventing HIV transmission. The report showed that 86% of American Indian and Alaska Native adult patients on antiretroviral therapy were adhering to their care plan. 64% achieved sustained viral suppression, and in the past 12 months before the study, 76% of American Indian and Alaska Native adult patients achieved viral suppression as of their most recent viral load test. The effects of underlying challenges faced by our Native people living with HIV are troubling. Approximately 50% are affected by poverty. Nearly 30% had symptoms of depression. More than 75% reported internalized HIV-related stigma, and 20% reported binge drinking in the past 30 days. From our healthcare providers in Indian country, we hear internally that substance use disorders pose one of the main barriers to treatment adherence in HIV treatment programs. Substance use disorders are overrepresented in rural and poor areas, and Indian country is no exception. Also, poverty can create barriers to consistent care, such as lack of transportation or unstable housing. The well-documented under-resourcing of IHS relative to other national health systems can mean there is limited access to behavioral health or recovery programs. IHS is making innovations in healthcare during COVID-19, such as telehealth. Still, our communities often do not have reliable internet or cell phone data coverage, so the digital divide has a more significant impact than ever before. Most troubling is the high proportion of patients who reported stigma. Stigma can have severe effects on treatment-seeking behavior, mental health, and the ultimate well-being and outcome of our Native people living with HIV. To reduce stigma, those of us working with Native communities must continue our efforts to promote a better understanding of HIV and the fact that we can treat and effectively manage HIV as a chronic disease. Thank you for listening to this HIV data report. I encourage you to stay in touch with IHS activities. To get regular updates from the IHS National HIV Program, please consider subscribing to our IHS HIV listserv. For more information, please go to ihs.gov and search HIV/AIDS. Please remember to check out cdc.gov for a variety of data and statistics on American Indians and Alaska Natives. You may also go to hiv.gov to help increase your knowledge about HIV and discover more about access to HIV services for people at risk for or living with HIV. For more information, please contact Rick Haverkate at the Indian Health Service by email at richard.haverkate@ihs.gov. Please visit our website at www.ihs.gov/HIV/AIDS. Hello, this is Rick Haverkate.
No, did it again. I thought I was gonna miss. Well, I really appreciate your time and attention listening to that. And that's available on YouTube. So I can send you the link if you ever want to use it for other presentations that you might have. But I wanted to know, just by show of hand or in the chat box, do people know where to get HIV data? One, yes or no? Do you know where to get HIV data? Two, do you find that data is difficult to interpret? So we can think of those later. Maybe we can have a discussion now or do a Q&A at the end. But I think what comes up a lot when we're talking to people is, why isn't there any data for American Indian Alaska Native people specific to HIV? This is what we're talking about today. And then if people do find it, often we hear that it doesn't include their community. It's confusing. Do we trust the data? So all those answers are always going to be different, I think. The good thing is we are working really closely with CDC, where we've got a couple of data agreements with Ryan White care facilities that are pulling out the American Indian Alaska Native folks who go for their care at Ryan White facilities. And those are normally located in larger communities, larger cities around the US. But we know most American Indian Alaskan people don't live on reservations. They live off reservation, oftentimes in bigger cities. So we think of like Denver, Seattle, Minneapolis, LA, New York City. A lot of our folks are going to these Ryan White care clinics. So like I mentioned before, we're losing them because they're not in that Indian health system. However, Ryan White is now pulling that data out and sharing it with us so we can compile a better visual of what it looks like. Are people staying in care? And the reason why we think that's important is because if we want to meet the goals of something called the Ending the HIV Epidemic in the US, started back in 2019, we're really going full force. Indian Health Service and our tribes and urbans finally got some of those funds. Not very much, but we're getting some funding to really figure out how we can help achieve the goals of ending the HIV epidemic. And that means we need to get 90% of people to know their status. So we have to do a really good job of getting people in for screenings. And I'll talk in a bit about how we get people in for screening and where some of those tools are. But 90% of people need to know their status. Because if you know your status, you either do things that keep you negative, or if you're positive, we get you into care. There comes the next step. Our goals is to get 90% of the people who are living with HIV into care, keep them there, and then get 90% of them to that undetectable viral load. So treatment as prevention. If we treat people living with HIV, we can prevent new HIV diagnoses just by getting people who are living with HIV into care because they're not able to transmit it. Study after study after study around the world has showed people who are being intimate with another person who's got their HIV under control are not acquiring HIV. We know it works. So 90% knowing their status, 90% into care, 90% to an undetectable viral load. If we can do that among American Indian and Alaska Native people, we can bring new diagnoses down to a level which we'll consider ending the HIV epidemic. The new diagnosis rate will come down so low that it'll no longer be considered an epidemic anymore. It'll still happen, but at a level that is much, much lower than it is now. And something that we're doing to help communities get better at this is something called our syndemic approach. So that URL I had right there, if you scan that with your smart, it's not a URL, a QR code. My vocabulary word right here, the QR code. If you want to take a picture of that with your smartphone, it'll bring you to something we're calling the syndemic approach. So in that, we envision a world in which all Indigenous people are healthy in mind, body, and spirit. The spread of HIV, STIs, and viral hepatitis is prevented. Every person knows their status and lives free from stigma and discrimination. And every person has access to high-quality, holistic care that reflects Indigenous values, which promote relationships with each other, the land, and all beings. So we have two big sources of funding from the federal government. One is from the Minority HIV/AIDS Fund, and that fund supported the development of this strategy. So Congress set aside $1.5 million to IHS. We, in turn, worked with our tribal partners around the country, had a really active group of about 25 people from around Indian country working in HIV that helped us put this plan together. We didn't invent the whole thing. There were 3 other strategies, STI strategy, an HIV strategy, and a viral hepatitis strategy. So we thought, instead of throwing 3 variety of strategies at Indian country, why don't we develop one and call it a syndemic approach? And we were a bit of the leaders on that. Now, HRSA and CDC and other people are talking about the syndemic approach, but we, with our tribal community partners in the country, really led the way in getting people to think systemic. And I think that's just because of our ability to think holistically. I don't think it was a big stretch for our people to think like everything's related, because it is, and we've known that. That's what our elders have always told us everything is related. So let's approach HIV in relation to those other factors. So in order to do that, and I think this is important, especially working with tribal colleges and universities and your integrated systems of care and learning and transferring information to our leaders of tomorrow who might be in healthcare, might be in economics, might be in engineering and other sciences. But this whole idea of how do we bring these core values in to talk about a syndemic strategy. So the core values from a variety of communities were things like balance and harmony, sharing wisdom, interconnecting with each other, the land, all beings. The foundational ideas of overreaching things like love, respect. We brought in some Native Hawaiian, so they talked about this idea of kuleana, the responsibility that we have that's we're born into, and we have as a community member just by being Indigenous. We have that whole foundation of responsibility for a community. So all these core values came into play as we put this together. And we looked at some strategies and components of how we would get these goals to relate to the types of local interventions. So things like talk about prevention and treatment, diagnosis, and how we respond to things like outbreaks in the community. And then at what level? So we have types of intervention and then levels of intervention. And those levels are individual and family and community, and then the whole healthcare system. So time for another commercial break. I want to talk about HIV prevention. And I would love it if you folks downloaded some of these and then shared them with student groups or faculty groups. They're all on YouTube. Maybe do a little plug and play. So embed them into some presentations that you're doing so people know that this information's out there.
Let's talk about HIV prevention. Those of us at high risk for getting HIV through unprotected sex or injecting drugs need to know about PrEP. PrEP is a safe and highly effective
bandwidth issue today.
Medication that can help prevent HIV. When taken consistently, PrEP can reduce a person's risk of getting HIV through sex by 99% and by more than 70% for people who use injection drugs. If you're at risk for HIV, it's time to make prevention a priority. Talk to your healthcare provider to learn whether PrEP is right for you.
So another little commercial around PrEP. It's so important that people know about PrEP. It's not that new anymore. Like I said, it's been around since 2012. I think it might be a little newer concept in some of our urban and IHS and tribal facilities. The good thing is the Indian Health Service has it on our core formulary for pharmacy. So it should be covered. It's not a cheap drug. It's around $1,200 per month. There's a generic form now that brought the price down to the maybe $35 per month, but it's no more expensive than insulin and it's life-saving. So if you know people for whom PrEP might be indicated, get them to talk to their IHS, tribal or urban Indian organization, healthcare provider. Are they hearing about PrEP in community clinics? Are you talking about it? Get people in the know about PrEP. If we can get at least 50% of the people for whom PrEP is indicated actually on PrEP, that's another great big giant step in helping us end the HIV epidemic. So who are those people that PrEP should be recommended? Got to be someone who's not currently living with HIV, so someone who's negative. Some of our clinics say anyone who's had an STI in the last year. So if you're talking someone who's had chlamydia, gonorrhea, syphilis in the last year, we should talk to them about PrEP. You saw the statistics earlier, about 86% of new diagnoses in Indian countries among men who have sex with men. Definitely should be talking to those folks about PrEP. People who had an unintended pregnancy obviously are not using condoms for contraception. So we should talk to them about PrEP. So PrEP isn't just for men, it's for women. Oh, and I want to say that we're trying to get really inclusive also with our language. And all the data you saw me talked about male, female. Definitely have to make sure that we are bringing in folks with different gender identities, people who are not identifying as either male or female. So we're trying really hard as much as we can to be very inclusive and talk about people living with HIV, people who are pregnant, people who have sex with other people. So help us with that change in our viewpoints. So I think it helps us lower stigma as well. So
Let's talk about.
I'm always struggling with how to move beyond. There we go. Okay, so next I want to talk a little bit about this thing called native test. This is free, available to anybody in the country by texting this number. So we've got some tribal folks at the Southern Plains Tribal Health Board down in Oklahoma who we fund to this national sending of HIV rapid self-test kits. We'll mail it to anybody free of charge. Text 55251. The words native test. we struggle with this a little bit because I think what's going to happen is people are going to see native test and they're going to think it's like a 23andMe thing. Oh, can I find out if I'm native by calling this number? That's not what this test is about. This test really is about offering a quick, rapid HIV swab. It's just one of those mouth swabs. But the cool thing this does, in addition to just mailing a test, we send out information for how people can learn more, talk to someone. What if the test shows positive? What's our next step? How do we get them into care that's culturally appropriate? So we encourage everyone to take the test. It's completely confidential. What we can't do right now, we don't really think it's a great idea. Say you called up, you're having a student health fair and you're like, well, I'd like to get 125 tests to put at our desk and people can just take them. You can do that. We can find out ways to get you that. But this system right here with the texting, we really want to make sure that we're individually connecting people to care. But if you do have some kind of a student organization festival and you want some swabs, let me know. We can get those for you too. But we want to make sure that people are in a system where we can text them back and forth and follow up with them and direct them to care where they live. So another really big step that we're doing, funded through that Minority HIV/AIDS Fund, to make sure people have access to testing. I wanted to play this little audio of someone that we found, a Native guy who really wanted to get the message out. So he worked with HIV.gov.
I'm a proud citizen of the Cherokee Nation, but I actually prefer chiffon and lace over buckskin and breedcloths. I'm what my people refer to as two-spirit. In my case, a gay man who embraces the male and female spirit within. We two-spirits are a special tribe within many tribes, and we face special challenges, including one that poses a threat to our health. HIV is a virus that impacts us. Ceremony, courage, and culture alone can't stop HIV, but there is something that can. PrEP is a medication that protects against HIV. I take it as prescribed to protect myself, my sexual partners, and the future of my tribe. I'm Anthony. I take PrEP and I'm ready to prevent HIV. Ready, Set, PrEP provides PrEP for free. Visit getyourprep.com to get started.
So another avenue that we're working with some national partners, they started a program called Ready, Set, PrEP. It's still going. We're not finding it to really be that successful in Indian country because it requires an enrollment from the person who wants PrEP. The tribal RHS clinic has to enroll in it. They have to send the person down to a Walgreens or a CVS to get the actual medication. So in theory, it was great. In reality, it's not working out so well, especially for Indian country, but we're working at ways that we can make sure people get that PrEP medication when they need it, how they need it, in a manner that's very affirming, that is free from stigma. So for now, we want to make sure people know about Ready, Set, PrEP, but the biggest message is just talk to your healthcare provider about PrEP. Talk about it in your communities, talk about it in your student settings, talk about it if you're teaching biology at a TCU. I mean, really just get the message out. PrEP is there. We can get you access to it. We're working on ways. I mentioned the injectable PrEP. That's once every 2 months. It's quite a bit more expensive. It's a little more time consuming for the provider, but Just think about how incredible it is for people who can get an injectable PrEP, just one injection every other month. No more worry, oh my God, I forgot my pill. Oh, I can't remember to get my prescription done, or I can't get back in to the clinic to go pick up my prescription. So getting that injection really takes a lot of the worry away from people. I talked to someone just last year who worked for a national organization that where HIV is actually in their name, but their national organization. He was an educator, an advocate, taking PrEP, was away on a trip and forgot his bottle of pills, called a local pharmacy, and they refused to give this, to fill his prescription for one reason or another. He ended up acquiring HIV. I mean, how silly and how wasteful and just how disappointing and sad that was, that he had a prescription for PrEP. He had been talking to his providers. He forgot his bottle of pills while he was on a vacation and ended up acquiring HIV. So that injectable PrEP would really help with that. But what goes along with this, I think, and we really have this big new agenda item, is to create PrEP navigators. So peer navigators from TCUs, from tribal communities, who are available to help people who've been prescribed PrEP. Like, hey, in this case, we'll use Anthony's name. Hey, Anthony, got a referral. Your doc said you're taking PrEP. You've been on it for a week. How's it going? Oh, you got a little stomach issues. That's really normal. Don't worry about that. But if you're having concern, come back into the clinic. Or, hey, Anthony, it's been 2.5 months since you got your PrEP prescription. You got to make an appointment because you have to come in to the doc every 3 months. Can I help you get your appointment? Oh, you need help getting? Can I get a CHR to come pick you up? Oh, you can't come in next week or the week after? That's okay. I bet I can get your doc to prescribe you another 7 pills until we can get you back into the clinic. Now, there's all these things I think we need to help people, and keeping people in care, giving them the support they need, helping them reduce stigma, making sure that that clinic is a welcoming environment. A lot of people, like, I'm not going to go to my tribal health care clinic because that's my first cousin working at the front desk. And if I tell her what I'm here for, it's like, maybe she doesn't know that I'm gay. Maybe she thinks I'm being promiscuous because I keep coming back for these PrEP pills. But so we have all these levels of barriers in a lot of our facilities, and we have to really help figure out how to do away with that, so people can come in and get on PrEP. People who are living with HIV can come in and get the care at their medical home. You know, somebody might be going over to that Ryan White Care facility while they're living with HIV and getting their meds there. They come back to the tribal clinic and they don't tell their tribal providers that they're also living with HIV. So, you know, maybe it's contraindicated that they're on a simple medicine for a general healthcare issue, but they don't tell their provider they're living with HIV because there's some shame involved in that. I think that's one of the biggest things, hurdles we hear about all the time, is the idea of stigma in our communities, and how do we overcome that? One of the things IHS did last year is started adding gender identity, sexual orientation to our electronic health record. And I have heard some really good success stories. There's still a little fear around that. I don't know how many tribal agencies are adopting IHS policies yet, but our EHR now says, as we go through your patient registration today, I've got a couple of extra questions for you. These aren't required. I'll use Anthony again, but Anthony, would you like to talk about your gender? Like, what sex were you assigned at birth, male or female? Usually it's only 2. It could be intersex, but basically it's 2. Our next question is, what gender do you identify today? And Anthony might say, I identify as he or she, or two-spirit. I know, Anthony, your formal name on your patient registration says Anthony. Is there another name that you would like to be known as today during your visit? Maybe someone is transitioning. So, you know, the same as my name is Richard, but no one calls me that. They call me Rick. So my preferred name is Rick. What does it matter if my preferred name is Rachel? I think that my provider should call me that name that I prefer today. They should address me with the pronoun that I choose, he or him or she or they. And that healthcare record should follow me all the way through my visit today. Patient registration, I see my nurse addresses me with he or Rick, and I go to pharmacy. And I expect the pharmacy is probably going to address me as Rick or Mr. Haverkate, or say pronouns that I want you to call me. So this shouldn't be foreign to anybody. It shouldn't be, that much of a lift for our clinics, our communities, settings, our patient records, any other kinds of records. That just respect people's wishes. Let's reduce stigma. Let's make everybody feel included. Let's get people into care and treatment. It's really just one of those small hurdles that make a great, big, huge difference in the end. If all of us felt welcome in all of our tribal IHS urban healthcare centers, and we all got the care we needed, how we need it, when we need it, I think it just solves everything. So we're really going at it from all different kinds of angles. That was kind of the end of my formal presentation. I would love to see if there's some questions I can answer, some ideas that people might have. We've got programs where people can help by volunteering some of your knowledge and your experience. I'm really excited about how we can work with some tribal colleges and universities to spread the good news and get more people involved. So I can look at the chat, or maybe Maggie can help me if there's questions that come up. But
yeah,
please.
so Rick, thank you so much. A fantastic presentation, very informative. We definitely have some questions in the chat. So if it works for you, I'm happy to read them, and then we can have some
Sounds good,
conversation
Maggie.
about it.
Yeah, let's do it.
So where could we recommend that tribal college researchers go to get access to HIV, HCV, STI databases for use in research projects?
Yeah, that's a good question. Research is a whole different game, isn't it? I would start with your the tribes that you work directly with. I'm really trying to focus, and we work really closely with our tribal epidemiology centers, but there's always this barrier of how do we get data sharing agreements in place. But what if, instead of going real macro, we went more micro? And, what if I was still living up in Sault Ste. Marie and I wanted to do a look at how is the Sault Ste. Marie tribe doing with hepatitis C elimination? Well, and this is a real case. We did fund them to do this work. So they're getting access in their own individual tribal patient records, confidential, with employees living and working there, to look at that data. How many people are in the patient records as being someone living with hepatitis C? All right, can they do follow-up on people who were tested, got a positive test, but we can tell no one ever contacted them and they never came back in for treatment? That's our first easy to reach. But so that's research data, but it comes from within. It's much, much harder to look at the big macro level, like signing data sharing agreements with states or the CDC. That data does exist already. And I would just advise people, instead of spending a lot of time and energy looking at how I get data sharing agreements in place, look at existing data. We are starting to publish some data from IHS. So try your area office, Bemidji area office, Phoenix area office, Alaska area office. But remember that those IHS facilities really probably only have data from Indian Health Service operated facilities. So tribes don't have to submit their data to an IHS facility. Some do, but they don't have to. Tribes own their own data. That's why I keep thinking, try working locally with some local tribes and empower local tribal communities, local urban Indian health organizations to look at their own data. That's just what I'm trying to advocate for, is like empowering local community-based research, working with tribes to empower them to look at their own data to see where they are on this continuum of getting access to care, initiating prevention, keeping people in treatment. So that's my little soapbox around data.
Thank you. And Reno, did you have any follow-ups? I know that was your question.
I took really good notes, and I'll probably review this video again, but for all kinds of research, getting access to the data is something we would like to help tribal colleges with, because our organization is really pushing for local research done by local people for local issues.
That really is the key. I think that excites me more than almost anything. We've spent years trying to get all these huge, big, massive data banks. But I think there's so much effort. It's never wasted, but it's just so much effort. But I love the idea of creating the empowerment of community level research. And then doing it with tribal colleges and universities, because you're oftentimes there in the community. I always think how amazing it is that people growing up on a reservation have a dream of like, oh, I'd love to be in healthcare or data or nursing or health promotion, disease prevention. I can go to school right here on my own reservation. I can get training with real life data, and I can go to work for my own tribe. I mean, how many people get to do that if you're not within a TCU kind of a reach? So I really like that idea.
All right. So another question, how does IHS utilize unique cultural aspects and attitudes of Native culture to address stigma and encourage testing and care? For example, I'm sure it is very different than working with large urban communities in the South, where most new diagnoses are found.
Yeah, I love that. I love the opportunity to work. So the first thing I do is I send as much resources as I can out to tribal communities and let them decide how it should be done. So I do very little design or implementation from the federal level. Our big partners are a place like the Northwest Portland Area Health Board, Southern Plains, Alaska Native Tribal Health Consortium, Phoenix Indian Medical Center, Great Lakes Intertribal Council, Great Plains Tribal Leaders Health Board. We work with all of those. I told you we get this Minority HIV/AIDS Fund that IHS applies for every year. It was about $11 million last year. Every single penny went to tribal organizations. And then we draw on them to help us with all those details, Maggie, at that last question. So we take our guidance from local tribal or urban folks. Oh, we also fund the National Council of Urban Indian Health to do some policy work around HIV, Hep C, and STI. So we get our feedback from them. We have work groups. I showed you some of those slides from the indigenous approach to the syndemic. All that came from local people, every single bit of it, the artwork, the details, the inclusion. So we work so hard to make sure that folks living in urban Native communities, in rural communities, working for tribes in metro areas and smaller and bigger communities, they control and input, and we take all of our guidance from them. Every bit of artwork, every language we use, we run it by work groups. So we're very deliberate and we hope strategic in the way that we bring the messaging back up for public consumption that it came from local American and Alaska Native communities.
Great, thank you. I'm just jotting down notes. Is it possible for programs that are recruiting AIHEC students into healthcare to post our commercials? Yeah, okay, to post our programs commercials in the IHS waiting rooms.
Yeah, no, it's not depending what the content is, you know, if Good Health TV wants to take it on. So what happens is there's this, I call it Good Health TV. They're owned by a group of folks called CAT Communications in North Dakota. So they create the content, but I think we can work out a way where we can make a commercial, or you can submit it to Good Health TV. And I don't know if there's a fee to for them to just take your commercial, but there's definitely each one of the tribal or IHS clinics have to pay a subscription. So it's like buying, you know, Hulu or Netflix subscription. Each one of those waiting rooms buys a subscription to Good Health TV. But I don't think there's any fee for submitting content. Probably would be reviewed. CAT TV would have a review board. Is this suitable? But yeah, I think the answer is yes. Let's explore that. I would love that. Again, you can contact me if it's specific to HIV, hepatitis C, or STI. If it's something else, maybe it's suicide prevention, maybe it's something around substance use. We've got folks that can reach out and help with that content too.
Great. Yeah, good question and good answer. Could IHS partner with a TCU or Indigenous health program to explore Native student attitudes towards PrEP?
Oh my gosh. Yes, I would love that. Help me organize that. I would do it tomorrow. Love that idea. I'm out here in Portland, Oregon right now. We're meeting with the Northwest Portland Area Health Board, and they have one of their programs is called PRT. Why can't I think of an acronym? PRT. I don't know what it stands for, but if you go to Northwest Portland's website, you'll find some opportunities where you can do just that. I would love to create those kind of groups, and we could do it through regional groups around the country or have one IHS group, but we've got funding to do that. I would absolutely love it. Fantastic idea.
Great. Yeah.
Please reach out to me directly with that.
Yeah. Wonderful. Moving right along, does insurance typically cover PrEP? And if a person is uninsured, or if it doesn't, do resources exist to support those that can't afford PrEP?
Insurance is supposed to cover PrEP. It's rated along the same line as insulin or most antibiotics. So there's a rating that it gets. So Medicaid, Medicare, VA, insurance is supposed to cover PrEP. Now, everybody's got a different plan, right? Doesn't mean because your insurance covers it that you buy into that specific plan that lets you have that prescription for $5. Your copay could be a whole different story, and that's all individual. But big answer is yes. Also, if you're eligible for Indian Health Service and you're going to a tribal clinic or an urban or an IHS facility, there should be no out-of-pocket cost for your PrEP. If you're living in an area, if you're eligible for IHS, but you know, like a lot of us, we live in urban settings where there's no IHS or tribal facility. There are patient assistance programs. Every major drug company, I don't want to promote any one drug company, but I'll use for an example, Gilead produces Truvada, the most common brand name for pre-exposure prophylaxis, PrEP for HIV. And they have patient assistance program, and they help people who are uninsured, maybe underinsured, and depending on what your needs are, they can work with you to give you absolutely free or at a much reduced cost. But then there's also generic. And I know lots of people are fine with generic. Some people it's not indicated, but generic PrEP is down to like $35 a month. But there's always avenues to go. There's I think it's called preplocator.org. So first of all, you might want to find out where is PrEP offered near you. So Prep Locator. If someone's on their computer right now, if they can type in, I don't know if it's .gov or .org, but it's Prep Locator. And it's on our IHS.gov website. But that'll help people find out where they can get PrEP closest to them. And that'll also helps with resources, how to help to pay for it. But if you're living near IHS or tribal or urban Indian health organization, reach out to them first and see what they say about helping cover PrEP.
Great. Thank you. Thank you. All right. I think we have just a few more. Does IHS EHE have funding that could be used to fund PrEP navigators at TCUs?
Was that, do they?
Yeah.
Was that first? Okay, yes. So we do have some ending the HIV epidemic funds. We're getting about $5 million a year for that. And I'm using that to build some competitive cooperative agreements. So we awarded 7 cooperative agreements last year. They just got into their second year of that. So some of them are looking at PrEP, but we do have funds at IHS headquarters specifically for that. So I'm happy to work with TCUs to do that. We're getting ready to do another round of competitive funds. That applications should be out sometime in the spring. Would love to see some TCUs apply for that.
Great. Okay. So I think that's it. I don't, just a couple comments here. Wouldn't it be great if IHS knew us by our tribal names? A comment. And then some thanks in here for the presentation. Does anyone have any other questions? We have just another minute or two before we
I'm
wrap.
gonna make a comment on something I didn't bring up yet. We're working on a policy for something called doxy-PEP. So people might have heard of the antibiotic called doxycycline. Lots of people take it for acne. People take it for so many other things. But one thing we used it to treat syphilis, but we're also finding study after study is showing that someone who was maybe out and about on the weekend or went on a cruise or had a really nice vacation and oops, I wasn't sure of my sexual partner's status for things like chlamydia, gonorrhea, syphilis, we can now get a prescription for post-exposure prophylaxis. So we can get you on a prescription of doxycycline for a certain amount of days after your exposure, and it's shown to prevent acquisition of certain sexually transmitted infections. So there's pre-exposure called PrEP, and then there's post-exposure. So there's DoxyPEP for lots of prevention efforts around specific sexually transmitted infections. There's also HIV PEP. So say someone had a exposure unknown, they think, uh-oh, the condom broke, I wasn't really good with my maybe negotiations around sexual activity, or there was a sexual assault, or you had a needle stick by accident, whether in a clinic setting or you shared needles or works and weren't sure of that person's status, you can come in and get the same medicine that we for PrEP, but it's administered under a different prescription, but you take it for 28 days after your exposure. The big thing is you need to get into a clinic ASAP. So definitely before 72 hours has gone by, but seconds count. So as soon as you think you might have had an exposure, call your clinic, call the ER. You can get on an HIV medication post-exposure to prevent the progress of the virus turning into actual diagnosis of HIV.
Wonderful. Well, Rick, we really appreciate you being here with us and presenting on this topic. Very informative. We're very grateful to you. We're grateful to everyone who was able to join us today. Rick still has his contact information up, so feel free. I'm thinking you can reach out to him as needed. And
Yep.
Rick, I anticipate AIHEC will be in touch with maybe some other ideas moving forward. So thank you all. We appreciate your time, and we'll see you next time at our next health webinar, December 5th. Look for
Thanks very much.
advertisement soon. Bye. Thank
Appreciate the
you.
opportunity. Bye-bye.